Good evening, dear colleagues and friends. Today I'm going to discuss briefly about prevention and management of hypertension during TAVR. Actually, Dr. Srinivas Kumar and we were discussing the hypertension issue, and we thought why not present our experiences with hypertension in the last 2 years doing 50 odd TAVR procedures in Apollo hospitals. So, this is basically our experiences and a few other points where we thought we could theoretically get hypertension. I have divided this into a few steps based on our procedures. Prior to the large bore access, we all know as interventional cardiologists, we are ready to deal allergy anaphylaxis. One patient we had in which, for all aortic patients, we give antibiotic half an hour prior to the cath lab shifting. This incidental, this patient didn't receive antibiotic on table. We realized he didn't receive. So before the puncture, we gave an antibiotic and checked after 15 minutes, patient had hypertension. Probably that's antibiotic induced. So it's always important for us to do all these things prior to shift to the cath lab so that we don't have any surprises. The contrast allergies, we all know how to deal with it. The second thing is anesthesia. Anesthesia, when we started our career in Tower, we did for all patients a routine GA, but after initial 4 to 5 cases, we shifted to a moderate sedation with local anesthesia, and we feel that the sedation with local anesthesia probably is the way to go. And there have been a couple of studies to show that the moderate sedation with local anesthesia is slightly better than GA, and we generally don't do a routine GA. What happens with sedation is the anesthetists typically keep on giving small dose of sedation, extra doses, what we say in black. Thing is, patient is slightly moving, they give another 20 ml of fentanyl, another 2 ml of propofol. That leads to hypertension. So we should be very, very careful, the anesthetist, not to oversedate the patient. The higher the sedation, the lower the blood pressure. So we should actually keep the patient slight conscious but fully unaware. During the procedure, this is very common for all the interventional cardiologists, vasovagal. If the patient is fully conscious, this is very common. If the patient is fully sedated, very uncommon. Because we do the patients in a kind of moderate sedation, we do experiences vasovagal on and off, but it's managed very easily. The only trick is these patients are sick patients. Majority have a severe dysfunction or a episode of heart failure or a functional class symptoms, are very elderly. So managing vasovagal sometimes becomes tricky. So always you require the help of anesthetist to manage carefully. Best is to prevent vasovagal by adequate hydration and also see that you don't undersedate the patient. The blood loss, hematoma, we didn't had any till now, but in intervention experience we did had. But that's the reason we always should understand that whenever we have hypertension before the procedure, these are the things we are supposed to look into. The vasovagal, if the pressure doesn't improve with your correction, check for the hematoma, local or a retroperitoneal. The TP lead perforation is nowadays we are seeing. Previously in last 15 years of experience, we never had anything, but last 2 years we had 3 perforations. We used to use the same 6 French lead. Now we shift to 5 French. But surprisingly, the new shift 6 French leads are slightly stiffer, I suppose. That's the reason they are perforating more often. One patient we had, this is not our patient, but we had lead perforation prior to the procedure. So these kind of patients, best is to avoid the tower, manage the perforation, manage the tamponade, stabilize the patient, bring the patient sometime back. But lead perforation, we usually see most common after the procedure. The next step, what we see hypertension is the crossing the wire. We use a stiff wire. What happens stiff wire is when we put the confit or the safari in the LV, sometimes the mitral cord get entangled to the safari. Then that leads to severe MR and hypertension. It's very, very important. Sometimes the stiff wire can also lead to severe AR. So combination of severe MR, severe AR can lead to hypertension. And the stiff fire also leads to arrhythmias. We can have VT, we have on table. Recently, we had a VF when Ramesh sir was there with us. We made a cardioverted. So very, very important for us to understand that wire itself can sometimes lead to hypertension by the way of creating arrhythmias or by the way of creating more MR and more AR. So next step is the dilatation of balloon. During the balloon dilatation, this is described. We never had annular injury. One of the first patients in Hyderabad had annular injury, and the patient was lost. That was probably 3 years back. After that, I don't remember any patient had annular injury in our experience. It's a dread complication. The only thing is to go for surgery. One more thing, what we frequently notice is in initial career, when we put long occlusions, pacing for longer duration of time, typically it's a quick inflation, quick deflation, and the pacing has to stop as soon as we deflate. But sometimes because of lack of coordination with the technicians or the cardiologist or technician become too lazy or sloppy, the patient is on for slightly longer time. Then we see this patient of hypertension. The hypertension sometimes takes time to recover. You need to give some small dose of NORAD or inotropes that actually complicates your process. The after balloon injury, we all know we can have severe AR. That's the reason we all keep the valve on shelf, fully prepared, fully check the valve, the direction, the loading. Then only we go for balloon dilation, because they have instances where the air was severe. We had one patient where the air was severe, and immediately we took the valve in and deployed it. So again, one more area, when we are deploying a typically self-expandable valve, this has to be deployed very slowly till we hear the rumbles. Once we hear the rumbles, we again go slowly till the valve is expanded. If you're too slow, the time is longer. Patient can have hypertension, irreversible complications. That's the reason we need to train slightly better in expanding the valve. The arrhythmias are always on the shelf. Whenever we are into the LV, arrhythmias are always there. So we should be always alert, and somebody has to check the monitor always to see for arrhythmias. We had experience with AF, we had with the flutter, we have with VT, we have with VF, everything has to be managed. And post deployment is very important. The most nervous moments for all the cardiologists. As soon as you deploy the valve, what you see on the picture, the worst thing what we can see is AR. Severe AR can sometimes lead to torrential hypertension. We had one patient, we immediately took another balloon dilated. The other thing is coronal occlusion or emboli and mechanical complication. We had three of these things. I'll show you. This is the patient who had a low coronary height. This is my wall. We actually positioned a 4 into 12 balloon into the LED prior to deployment. As soon as we deployed, patient crashed. Pressure zero, asystole, heart block. Immediately, we were actually geared up for this thing. That's the reason we took the stent back, deployed there. Then you can see the flow improved. It is very important to actually analyze the CT prior to doing, so that these kind of complications are anticipated. With this evolution of CT and multiple opinions, these things can be avoided, that without our knowledge, the coronary gets occluded. And this another patient on a colleague, what happened was patient's successful tower was done. In ICU, patient developed ST elevations in the anterior leads. Patient was brought to the cath lab. It's 3 to 4 hours after the procedure. What we see is the LED is occluded from mid segment. Patient had a normal angiogram prior to almost 3 days prior, had normal angiogram. So this shows a occluded mid LED. Then was wired, then ballooned, then had a TIMI2 flow. Probably thought one of the microemboli could be a valve calcium or could be a thrombus, because the long procedure would have embolized into the coronary, and that led to ST elevation. But patient came successfully. The pain got relieved as soon as we did a balloon, and patient recovered. So these are the things we are supposed to remember. Any ST elevation, even normal coronaries, embolus do happen. This is an interesting patient which we presented in the TCT 2 years back. This is an elderly lady. We did a tower with a Medtronic valve. After that, we heard a murmur. Then we thought a small ASD 2 millimeters was there, VSD 2 mm was there. We left it alone. But after 2 days, patient rapidly iterated. We did a TE. You can see the septal rupture with a free leak between the aortic valve and the RV. This is a large VSD. Patient was becoming restless. Hemodynamics were going down. Then we explained family, took to the cath lab. We used 2 plugs, one from the RV side, from the aortic side, to close the defect. Ultimately, we could close this time. We learned that the core valve can be crossed, the hole can be entered. We can use a 6 French sheath also there, and the valve didn't get damaged. This is the TE post the deployment. You can see nicely closed VSD. After dilatation, we have this strange patient affair. Recently, we had wall migration. We never had. Probably yes, we have witnessed ourselves in the live conference and the case reports. Wall can pop in, pop out. Pop in leads to problem. Pop out leads to severe air hypertension. So you be ready with another valve. That's the reason all the company people bring 2 or more valves with them. Another issue can be seen when you are aggressively post dilating the valve. In India, what we see is a lot of calcium is sometimes eccentric. One of the analysts has a calcium, you have an orifice which is not fully circular. We tend to over dilate to make it circular. Sometimes during these over dilatation, we can have severe annular issues. This recent patient, this patient had a, I'm sorry for the bad images, but this cell phone recording, this patient had a moderate AR after the deployment. We thought we went for a perfection. We dealt with a 22 Zemet balloon. then what we had was a more severe AR. So we are worried. We are almost taking for another valve and balloon was ready, but wait 15 minutes on the table, it's settled. Sometimes what happens is the internal, as the warmer it gets, the wider it becomes. So sometimes in 15-20 minutes, the nitinol outer sheath tends to get enlarged and the air comes down. That's what happened with this patient. Post procedure, the TPA lead is the single most common reason for us to worry. That's the reason nowadays our practice is to remove the TPA lead on the table. We don't keep the TPA lead beyond 1 hour of procedure. We have an ECG as soon as the procedure done. ECG, no bundle branch block, everything is normally take the lead out because we had two lead perforations. One patient had perforation the next morning when she was trying to sit up. Probably there's deficiency of nursing care there. Secondly, perforation happened within 1 hour of the procedure. Both times we did auto transfusion. It took a lot of time for us. The hematomas are routine. We can see in any intervention like access site hematomas or retroperitoneal. These are common like any procedures. So this patient testing, what we had was, I'm sorry, a small aneurysm after the procedure, hypertension. We actually occluded the balloon, did a glue injection that it healed. Nowadays, we do all the vascular punctures with a small iPhone kind of a device by GE to have a good vascular access. With this device, we can actually pinpoint the vascular site where we want. We actually go with the injection contralateral, do a Doppler, and exactly locate the area where we want to puncture, where there's no plaque, because we already have a CT image to understand where the calcium is there. So we try to identify the area where there's no calcium in the posterior anterior wall, and we puncture exactly the place. After that, probably our results are slightly better vascular wise. Thank you.